This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, a senior attending neurosurgeon.
And I'm Dr. Alara, a research fellow. Today we're looking at a fascinating new study from the Journal of Clinical Neuroscience, the official journal of the Neurosurgical Society of Australasia, specifically their 2026 issue. The paper is titled Occurrence of Hemorrhage or Radiological Progression of Residual Cerebral Arteriovenous Malformations After Incomplete Surgical Resection.
This is a topic that hits home for anyone who has spent time in the OR dealing with complex AVMs. We always go in with the goal of grade 0, total obliteration. But as we know, whether due to deep perforators, eloquent location, or intraoperative hemodynamics, we sometimes end up with the residual.
Exactly, Dr. Aris. And the core of this paper addresses a major gap in our literature. We have a fair amount of evidence regarding incomplete obliteration when it comes to radiosurgery or embolization. The general consensus there is that incomplete treatment doesn't really alter the natural history of those lesions. They still carry that persistent risk of rupture.
Right. The natural history is the baseline we're always fighting against. But the authors points out that we've lacked that same level of evidence for incomplete treatment, specifically within the realm of microsurgery. When we leave a surgical residual, are we looking at the same risks as a residual after radiation?
That's the question. The study looks specifically at two primary outcomes, the occurrence of hemorrhage and the radiological progression of these residual AVMs. It's about understanding if that leftover nidus is a ticking time bomb, or something that might behave differently because the hemodynamics of the surrounding brain have been altered by the surgery.
And there's a specific phenomenon mentioned in the abstract that I find particularly challenging for clinical decision-making. They mention case reports of spontaneous obliteration of post-surgical residual AVMs.
It's a bit of a neurosurgical paradox, isn't it? You leave a piece of the malformation behind, perhaps because it was too risky to take, and then on follow-up imaging, it's gone. The paper suggests that these instances of spontaneous obliteration really complicate our decision-making. Do we go back in? Do we send them for gamma knife? Or do we wait and see if it disappears on its own?
It puts the surgeon in a difficult spot. If the natural history remains unchanged, meaning the hemorrhage risk is still there, then waiting is a gamble. But if there's a chance for spontaneous obliteration, a second surgery might be unnecessary morbidity.
The paper emphasizes that while we know the natural history doesn't change much for embolization or radiosurgery residuals, we can't necessarily transpose that data to microsurgery. The mechanical removal of the majority of a nidus and the cauterization of feeding vessels creates a different physiological environment than the gradual thrombosis of radiosurgery.
That's a critical point for our residents listening. When you're looking at post-operative imaging and you see that small blush of residual, you have to ask, is this radiological progression? Meaning, is it going to grow or recruit new vessels? Or is it stable?
And that's what the study investigates, the occurrence of hemorrhage or radiological progression. They really want to define whether these residuals are dynamic. If they progress radiologically, it suggests an active, aggressive lesion.
This study is a call for us to be more rigorous in how we follow these patients. We can't just assume that because the bulk of the AVM is gone, the patient is safe. But we also have to weigh the reality of those spontaneous obliterations.
It really highlights the need for dedicated post-surgical monitoring. For the medical students and residents tuned in, the key takeaway here is that incomplete surgical resection is its own clinical entity, distinct from the residuals we see in other modalities.
Well put, Alara. It's about the nuances of incomplete treatment. We often treat AVMs as a binary problem. Either it's there or it's gone. This paper reminds us that the residual exists in a gray area of neurosurgical evidence.
Definitely. It's a fascinating look at the long-term behavior of these lesions. For those interested in the full dataset on hemorrhage rates and the specific percentages of progression versus obliteration, I highly recommend reading the full text in the Journal of Clinical Neuroscience.
It's essential reading for anyone planning an AVM resection. We have to know what happens if the plan doesn't go 100% according to script. Thank you for joining us on the Neurosurgery Hub. I'm Dr. Aris.
And I'm Dr. Alara. We'll see you in the next episode.